Anjali Nayyar. Actually, very briefly, if I can introduce her in one line, Anjali has more than 20 years of experience in global health services. But it'll just take a couple of minutes if I very briefly give her the details, brief details. I know it's a kind of an oxymoron phrase, but that's what it is. And if I can use that oxymoron, brief details, her experience, Anjali's expertise lies in developing integrated strategies to impact health policy and practice in Global South. She oversees the organization's programs. That organization is GHS, Global Health Services, in emerging markets in Asia and Africa, working through 4 offices and networks of independent consultants. But very briefly, prior to this GHS, she has served as country director for Program for Appropriate Technology on Health. Yes, Program for Appropriate Technology on Health, and its appropriate acronym being PATH in India. And preceding PATH, she worked with the International AIDS Vaccine Initiative, IAVI, and has been the global, as vice president of this particular organization. She had led the field operations and non-research programs in India, Brazil, South Africa, China, Kenya, Rwanda. She is a member of Confederation of Indian Industry, CII, National Committee of Public Health, and a member of advisory group using to end neglected tropical diseases. So she has had a vast experience in this health sector, from AIDS to neglected tropical diseases. But for the moment, we are inviting her amidst this corona pandemic. So it's my proud privilege. I'm delighted to introduce to you in this webinar Anjali Nayyar, Executive Vice President, Global Health Strategies, GHS. Over to you, Anjali.
Thank you so much. I think the bio sounds far more impressive. Some of the speakers before me and those over here have had equal, if not better, experience in public health in India. It's always a challenge to be the last speaker and an opportunity. I mean, of course, it's a challenge because everyone has said everything, and opportunity, you kind of can say something else beyond what everyone has said. Also, the biggest challenge is you're really between lunch and everyone on the panel and participants. So I'm just going to keep it very brief. I'm going to make just 4 points and then, open it up. Any questions that you have. I think, we all recognize this, but the survival and health of our citizens is really one of our greatest paradoxes. Our healthcare facilities across the country have different levels of efficiency and care. On one hand, we are global leaders in innovation and quality of care. We have globally renowned medical and teaching institutions, but we also know that many Indians, especially the poor, receive very, very poor quality of care, despite efforts and despite whatever that we've done thus far. I also think that, public health has never received the kind of attention it deserved. While a lot of us who've spoken today, and I'm sure yesterday, know what public health and healthcare in India is, vast majority of people we interact with, it's 2 different things. Healthcare is either large private hospitals for those who can afford it, and they read stories about outbreaks and conditions, and it's kind of really far away, not touching them. So there is not that level of interest till today. In classic economic terms, everyone recognizes that healthcare is a public good, but we don't practice it, So far, that's why so far we've got away with not providing universal healthcare or quality healthcare to a vast majority of our population. And today we are seeing that we will end up paying a fairly heavy price, or are already paying a very heavy price. And one of the impacts of this COVID-19 experience is that it's brought public health care and it's given it the kind of attention, not just as a health problem, but also as a policy and economic rights, everything that a lot of us have been talking about. And Anand uh, has been one of the biggest proponent of this, that healthcare cannot be seen in isolation. Uh, Disease outbreaks at whatever level, whether it's COVID or whether it's TB or whether it's cancer or heart disease, does not just affect an individual. It affects a family, it affects a community, and ultimately it affects a country, because uh, healthcare, because we look at healthcare, the impact of healthcare on productivity. A lot of people support their families. A lot of people get into poverty or take loans for healthcare for a member of their family. I read a very, very interesting article about a couple of years ago when we were talking about farmer suicides. And this article in Indian Express said that at least 30% of the farmer suicides were loans that were taken because of an health episode in their family. So you can see the kind of impact healthcare has. And to that extent, I see an opportunity in this outbreak that suddenly we are saying, okay, healthcare is not just about disease. So that's one thing. I mean, we are today talking about investing in health is like investing in a healthy, productive, and an economically sound society. To me, that seems to be an achievement in itself. I do hope that as we get past this pandemic, we continue to feel this way. You know, it was really interesting to hear Mr. Vineet Chaudhary and others that after H1N1, all of us remember the long lines outside hospitals for testing, the panic and the cry for vaccines. And suddenly we had a drug and the vaccines were forgotten. But I think as we move, we continue the focus on healthcare. We continue the focus towards our path to universal healthcare and universal health coverage. I think we definitely need to start looking at a sound disease surveillance. We need to look at an integrated primary healthcare system that can provide services at the village level. And we need a strong tertiary care where most of the technologies that are available in a large city hospitals are available there. And we need extra capacity that can take care of any future health surges. You know, it's interesting that in 2018, the WHO technical committee on epidemics had warned of a similar pandemic. No one paid any attention and no one even prepared for it. And I think we need to really, really learn from this. The second point I want to make is public-private partnerships are key. And I read a very, very interesting line, which was really in one of the newspapers, which was about COVID, but I think it could apply everywhere. You know, the government has looked at public health care as a whole of government approach. You know, they do what they do, and there is a private sector that kind of is there outside providing services. But I think we need to start looking at a whole of society approach. And that really is important for healthcare. You know, we have initiatives like Narayana Hridayalaya. We have initiatives like Arvind Eye Care. These are case studies that can be translated and really have very important public-private partnerships. We work in the states of Maharashtra, Bihar, and in Rajasthan, where we are bringing governments and private providers together to provide TB services. Given that 70% of the people go to private care, it's really important that government and private health care get together. We have seen in private sector that some of the regulations are not followed strictly, and in some of the governments to that extent are bound by the policy and guidelines that they develop. So I think bringing those two together to look at a holistic affordable approach with tiered pricing is really the answer, and I do hope that everyone works toward it. I also remember, with private sector, you get increased testing. You get the kind of, you get the X-ray machines, you get the diagnostics you need. There is no reason why I need to go to a doctor. I can get my test, I can get my X-ray all in one clinic, and a poor has to run pillar to post. So we really need to bring these partnership together. The second thing is drugs and diagnostics. And I have been criticized about this, but I continue to believe in it. If there are drugs and diagnostics available in the private sector and those who can pay for it get it, there is no reason why the rest of the society can't. We have Indian innovators. The Bharat Biotech brought about a vaccine against rotavirus diarrhea, which is a fatal diarrhea, and they brought it at $1 a dose. When hepatitis B, when Indian companies started manufacturing hepatitis B vaccines, it changed the world. Prices came down. We know the drugs that Cipla brought for HIV. Prices came down across the globe and access increased. So Anant is right. We need to invest and we need to make sure that globalization, at least insofar as medical technologies are concerned, continues. Tomorrow we will have a COVID therapy or a vaccine for it. There is no reason why we shouldn't start talking about compulsory licensing today and making the plans today that everyone receives it. So I think those partnerships and those discussions are very, very critical. The second thing, and I think Dr. Ahmed did talk about it, is disruption of services during epidemics. We've seen heartrending stories, not just about the migrant workers, which are terrible, but also about people running from hospital to hospital to get the healthcare. I know that there are several anecdotal stories coming out where pregnant women, when they go to hospital, are first asked to do a COVID test while the woman is in labor. We need to start providing those services. We need to have that compassion, that empathy to provide the services as COVID tests happen. We know that there is disruption in TB care. We know there is disruption in cancer care. And I think that is urgent. So however we can get those stories out, however we can make sure that those services are available is really important. And my last point is about stigma and discrimination. We know that stigma drives disease underground. We've seen it with HIV, we've seen it with TB. We will see it with COVID-19 if we don't take stigma and discrimination again. This othering of disease is the worst thing possible. You know, it can only happen to others. It can never happen to me. Therefore, I need to protect myself so that I don't get it from others. I don't think that's true anymore. If you look at the global burden of disease numbers, India is among the highest in communicable and non-communicable diseases. And that's not all poor. The poor are affected because they don't get the health care that they need. So they are worse off. But disease is an equalizer to that extent. So I think we have to make sure that we get the message out and about stigma and discrimination. So I'm going to stop there. And I know it's almost 1:30 and everyone needs to go for lunch as well.
Don't worry at all, Anjali. You have been wonderful and so considerate about the lunch. But let me assure you, we have already extended the session till 2 o'clock. So there's no worry at all. We have time at our hand. So you may please continue for a few minutes if you want. 1:30.
No, I think I'm ready to take questions. I've made my points.
Okay. So the first question that I would just like to put to you has been from Vineet Chaudhary, who was also our one of the esteemed guests. What would be the career graph of a public health specialist in the state? Would you agree that public health should be opened up to non-medical persons as has been done in UK?
I absolutely agree. I think, we have medicalized healthcare, and public health perspective is very, very important. There is a lot of MPH degrees, Masters in Public Health, that are provided to non-medical persons. And I know that PHFI was supposed to do just there. I don't know how they worked it out. The important thing is that we don't have a clear career graph unless there are employment opportunities and career graphs as much as there are for medical degrees. Not many people will go, though I have to say a lot of non-government organizations, a lot of donors, and a lot of international organizations working in healthcare are increasingly hiring public health professionals. We just need to get them out there.
Okay, thank you, Anjali. And in fact, the questions are overlapping because it's being addressed to you as well as to Dr. Ahmed, the preceding guests. So can I check with the audio of Dr. Muzaffar Ahmed? Are you there, sir?
Yeah, I'm here.
Okay, so this question was for you as well. So would you like to respond?
Yeah, please.
Do I read out the question to you?
Yes, yeah, please.
What would be the career graph of a public health specialist in a state? Would you agree that public health should be opened up to non-medical persons as has been done by UK? Anjali has already responded. It's your chance, sir.
Yes, I agree that this should be open to non-medicals as well. We have the role and responsibilities of non-medical in the public health is quite vital. If we take the non-vector, vector-borne diseases, unless we have a good entomologist, we won't be able to take care of the outbreaks of dengue, outbreaks of malaria, and other, even JE and AES. So the role of non-medical public health specialists is there, and what is really required is their career in the system. I'm sure there will be thinking, and we need to have a system where we have to take care of their career progression, and so that they are useful in the system.
Yeah. Now there's a prince also. There's no prince of kingdom. किसी राज्य के राजकुमार नहीं है. उनका नाम ही है prince. So this question comes from Prince, and it's addressed to you, Dr. Ahmed.
Yes.
He's from PPF itself. The person who's putting the question. The question is, if there is a vaccine developed for COVID-19 in near future, as is claimed by many institutions, what would be the standard response of the government to administer the vaccine to the people in an effective manner? Because you've been a government civil servant also in a way. Dr. Ahmed.
Yeah. You see, once the vaccine will be developed, hopefully, as per the news, it may be by the end of the year, it will be developed. And once it is tested, clinically tried, and appropriately, allowed by the Drug Controller General of India. And question is about the pricing. And hopefully the pricing in the Indian context should be affordable, not only for the government sector, but also in the private sector who will be able to pay. And I think this will be taken up in the due course of time. The way hepatitis B vaccine was taken up, initially it was very expensive. People were not able. Now even the people they're buying it, and even in the system, the government is now providing the hepatitis B vaccine. So similarly, this vaccine will have to also be provided to the community.
Okay, thank you, Dr. Ahmed. Is Anjali still there? I can see her, but there was a guest, Professor Anita Kai, yesterday. She is like requesting a comment from you. She says, I set up the first MPH course in Pune University. Can I please get a comment?
Hi, Dr. Anjali. To mention, the Master of Public Health has a tremendous career opportunity, and I'll say it in this way, that people like in the positions that you've worked my students, it's been, I'd say 15 years now, they're creeping into these positions now. You know, every discipline, when you initiate it, there is a trajectory, there is a small, it takes some time, but we can see our students now becoming country heads of different programs, you know. Now, the problem that I envisage, and Dr. Ahmed was talking about career trajectories, is there is very little understanding of what is public health. So this community engagement, the ability to map disease, map risk factors for disease outside primary health centers and sub-centers, that's the skill that our students who complete the Master of Public Health, they have. They will not be able to treat a case of COVID, but they can tell you how the disease and its risk factors are distributed through the population. So this is the point that I just wanted to make. Thank you.
Thanks a lot, Anita Karji, because I was slightly amused. What does MPH course stand for? Now you have clarified it's Master of Public Health. Yes,
Public health.
you can respond.
Yeah, I'd really like to congratulate you, Anita. I think today, I mean, we have, of course, we have medical professionals, but we have more MPH persons with MPH degree working with us. And you're absolutely right. I think the experience and insights they bring to public health is very, very valuable. So congratulations for setting up this course. I also wanted to point out about the earlier question about, you know, if a COVID vaccine is available. I think we're seeing some astonishing and wonderful collaborations today. There is the Solidarity Trial by WHO, which really which has made a commitment for access. We've seen Gilead with remdesivir already signing off, getting off the patent and enabling countries to manufacture. There is a letter written by country leaders that COVID vaccine should be free because it is going to be a public good.
Yeah. Now, my co-host Dinesh ji also has a question for Dr. Ahmed. So, Dr. Ahmed, are you there?
Yeah, I'm here.
Yeah. So,
Dr.
Dinesh,
Ahmed?
please,
Yeah.
Dinesh ji.
Yeah, Rajaji. Dr. Ahmed, I have two questions. You said about safe care institutions. Can you explain safe care institutions? And there's in our sessions, there was one thought, there was one idea that there should be separate cadre for the health services. Do you agree with it?
Well, first is about you mentioned about the safe. I said the safe healthcare institution is important. Unless and until we make our healthcare institutions safe, then only it will be able to function. So it has to be safe, not only structurally, the building, but the equipment has to be safe. Even the people have to, the functionality, it has to be functionally resilient in order to meet any challenge. One. And second is about the cadre. I couldn't understand what you said about the separate cadre for medical.
Yeah, health services, yeah.
Health services. You see, there was a thinking long back that Indian medical services cadre will be established, there will be a separate cadre. I don't know what happened to that, but there was a thinking that there should be a separate cadre for Indian medical services. I don't know how much that will go, but what in the present circumstances, what is important is development of public health cadre in states. It is very important. And again, I would like to reiterate that it's not only the medical personnel doing the MPH, but also non-medical persons whose role is equally important and critical and crucial to meet for the health sector. This is really important for as far as the public health cadre is. And also we have to also understand in pandemics and even any outbreaks, what I say is it is the public health in emergencies, not public health emergency. In public health in emergency, it is everybody's responsibility. Everybody becomes the stakeholder, whether medical, non-medical, everyone. That's important.
I like the way the moment we are started moving towards the end of this webinar, more and more thought-provoking questions are cropping up, and this is the first time it's like overlapping between the two guests. So this question comes in way of Anjali Nayyar, and the person who's asking is Mashkur. The question is, can you please elaborate on the point disaster as an equalizer in the context of public healthcare in general and COVID-19 in particular? Anjali?
It is, okay, it's an equalizer to the extent that when there is a health episode in a particular family, a serious health episode in a family, it's not just the individual that gets impacted, it is also the entire family and community that gets impacted. That's number one. Number two is that cancer, tuberculosis can strike anyone. It's not just an individual, and the treatment for both of, whether you're rich or poor, will probably be the same. The care will be different and the access will be different, yes, but the fact that when the disease strikes you, it can strike anyone. So to that extent, it's an equalizer. With COVID, it's, you know, when you look at countries in the north and you look at countries in the south, earlier on when you saw an epidemic, Ebola killed more people, but there wasn't a global outcry to the extent that we are seeing because it was isolated in a particular nation region. And it was seen far out, and it was that, you know, oh, Africa does have these crises, and that's okay. COVID-19 has impacted the world over, and in fact it has impacted countries in the north, the first world countries, much more up to now. We still have to see how the epidemic rages in the global south.
Okay, and it's really getting very interesting because now the question that's coming up, it specifically says that it's for both in the sense, both Dr. Ahmed as well as Anjali. So, and the person is Nandita, and Nandita has specifically written, my question is to both Mrs. Anjali and Mr. Dr. Muzaffar Ahmed. What should, and I read out the question to both of you. What should be our take on deaths at home which go unreported? Should this data be included in the data pertaining to COVID-19? And what would be its effect and relevance will it have on numbers of mortality rate during this pandemic? Nandita asks you both. Anjali, you first.
I think Dr. Ahmed should go first, but I'm very happy to respond to it after him.
Okay, Dr. Ahmed.
Yeah. See, it is the people dying in home and not tested, whatever the cause may be. We can't, you know, really attribute that to the COVID. You can't. You see, a healthy person may get a heart attack or in cardiac arrest, or one, but you can't say that he has died due to COVID. One. Second is, but if a person who has to undergo dialysis, weekly dialysis or twice weekly dialysis, he is not able to get his dialysis and he dies. We have to attribute that because of the COVID, he couldn't get his dialysis and he died. But what is really required is the data collection. You know, there was a debate for the deaths occurring in UK, the number of deaths in the hospitals, as well as the number of deaths in the elderly homes was a big question. Whether there's a system of data collection, and that is an important. How do we make a system to have data of deaths, whether at the home or in the hospitals?
Yeah. So, do I go to the next question, or Anjali, would you like to reply briefly?
No, I think Dr. Ahmed is right. I mean, COVID deaths are those who have tested COVID positive. Now, there could be deaths at home which happen due to a pre-existing disease already, or for any other reasons, where a patient does not show the symptoms of COVID-19. You can't include that as a COVID-19 death. I also think that the way COVID-19 deaths are counted is those who have tested COVID positive. And not because of the COVID epidemic and the death had happened. So I think that's how the deaths are calculated.
Okay. During those about 25, 30 years of my television career, the success of any television program when we leave the phone lines open is how many questions are there. Log khushi, acha, 1000 sawal po aaye the, utne aaye the, and we couldn't take them all. So it's my pleasure to inform all of us that as we are approaching the close of the show, we are having quite a few questions, and it's our discretion, rather my discretion at the moment. So I'm making a kind of a rule because I cannot accommodate it all. So the first timers, I'm taking their questions first. First timers in the sense, for the first time, if that person has asking that question. So with your permission, I'll take the first timers first, and then if the time permits, then the rest as well. So this is Nazima or Nazima, if I pronounce this correctly, asks, what are the possibilities of voluntary sector organizations to cooperate in the health sector? Anjali?
Oh, as I've mentioned, private sector has a huge role to play, and I don't just mean private hospitals. The voluntary sector. Historically, India has had a very active voluntary sector, and they've done some amazing work. I think where we've kind of fallen short is their innovations are not always either scalable or have not been scaled up. So, but the voluntary sector has played an immensely important role in providing health services and health information to people.
Okay, now quick observation from our one of the guests earlier, Vineet Chaudhary ji, and he's addressing it to another of our guests earlier. You are so right, Dr. Carr. I think it's Professor Anita Carr. There were not many takers also for the 1.5 million doses of H1N1 vaccine that were imported. The indigenous manufacture of the vaccine is sad case of an opportunity lost. So it is one of those things which we need to improve upon. But as I just mentioned, I'll take another of the first timers, Manika. Her question or rather observation is a bit long, but I'll try to make it crisp. And it is addressed to Anita Nayyar ji. Hello. Are you there, Anjali? Anjali?
Yeah, I'm here. I'm here.
Yeah, sure. So I think because Manika begins with a ma'am, so I guess it will be your address to you. Ma'am, you have rightly put that health being a public good sets the context for universal healthcare. However, considering certain features which make health services distinct from other goods such as uncertainty, insurance coverage, and asymmetric info and other externalities, what policy measures may now prompt ensure universal health coverage?
I think the answer to this question is a webinar in itself. Yeah, because there are a lot of things and we've had some fabulous reports and writing on what really will make for universal healthcare, and I'm very happy to send some of them to her. There's a particular good paper written by Dr. Srinath Reddy, and of course, WHO has put out what are the elements of universal healthcare and universal health coverage, and what countries can do. But if you look at the Thailand model, it's a mix of strengthening primary health care and an insurance model. So I think we really have to do a combination of both. But if I have a minute, I would really like to respond to Dr. Carr and Mr. Vineet Chaudhary's conversation about the H1N1 vaccine, it definitely was an opportunity lost. There was a huge outcry for the vaccine, and soon we had a drug therapy, and then people realized that this was a severe kind of a flu, and you could fall sick, take Tamiflu, and you would recover. And slowly the mortality rate went down. I think H1, I could be wrong, but I think COVID vaccine will be a completely different thing. Number one, because of the infectious nature of the virus. It infects far more rapidly than the H1N1. And the second is the incubation period. You could be asymptomatic from 2 days to almost 12 days.
14 days
yet
maybe at times.
14 days they add, but I mean, if you look at it, let's say 4 days, 2 days to 12 days or 14 days, you could be COVID positive and continue to infect. So I think for those two reasons, probably most countries will want to give universal access to the vaccine.
Okay, so now we are moving towards the final question of this webinar, 2 days webinar. And the final question is very brief, but related to one of the poorest states of a country, Bihar. और ये प्रश्न पूछने वाली है पूजा, PPF से ही जुड़ी हुई है. Pooja asks both the preceding guests to respond, Anjali Nayyar and Dr. Ahmed. The question is, how we will tackle this COVID-19 in our poor state like Bihar, where testing is very, very low. Anjali, you can take it first.
It's a big challenge. And I do believe that one of the worries about the migrant population to go back was precisely this, that our rural sector does not have the right kind of facilities, which is not to say that the governments are not doing a good job of getting the tests out, but it is a big challenge. To me, the bigger challenge is also the infodemic. We have to make sure that everyone wants to protect themselves. We need to make sure they get the right kind of information. They can't do any kind of physical distancing. I don't like the word social distancing. We are socially active. It's the physical distancing. They can't do it. But within that, what is it that they can do? And that information, unfortunately, is not getting out to them. I think today we're also, with the migrant population going back, as Anand put it so well, we're not just looking at prevention of the disease, we're looking at other illnesses as health services are getting disrupted. We're looking at hunger back in homes. We're looking at malnutrition. So I think it's a very big challenge in front of us. Bihar actually is not doing so badly in terms of the health services. They recently restarted immunization services. But in terms of COVID testing, I'm not sure if the lockdown has enabled states to ramp up the kind of testing that maybe Maharashtra is doing.
Yeah.
I would also like to add, yes, I would also like to add that Bihar, over the recent years is doing very well as far as disaster risk reduction is concerned. This is rather the first state in the region, I would call the Southeast Asia region, who prepared a roadmap for 15 years for reducing the disasters, risk of the disasters, and the massive program for capacity building of urban local bodies, panchayati, the people working in panchayati Raj, and also the investment in the capacity sector, and also in health sector. Bihar is the place for, they had large attraction of doctors. They enhanced the age of superannuation to 67, tried to engage doctors at higher rate. And I'm sure with the, the political backup, they have a initiative, they have established, they have now a task force directly working under Chief Minister, where they should be able to take care for this, the present situation as well.
Okay. Thank you so much. Thank you so much. Dr. Ahmed, thank you very, very much. Anjali and all of you, सप्तर्षि जो हमारे हैं, सातों जो मेहमान पिछले 2 दिनों में थे, उनका बहुत बहुत धन्यवाद. And that brings us to the end of this webinar.